a dilemma we have in the same person doing the both. But okay, we'll enjoy for sure. Thank you very much for taking this burden.
Yeah, thank you very much. I'm more con, but I will try to be fair and to have some arguments for pro approach. So these are the randomized clinical trials in cardiogenic shock. So this is what we know. We know that revascularization improves outcome. We know that type of revascularization, so culprit lesion only improves outcome. About vasopressures, we are not sure. And if we come to mechanical support devices, intra-aortic balloon pump didn't do the job. And the same is true in a small randomized trial for mechanical circulatory support devices. So we are not even sure if ECMO improves outcomes so far in cardiogenic shock. And why is this the case? We have problems with mechanical support devices in cardiogenic shock. So we are not sure which support device should be used, which is the optimal timing, and this is a crucial issue. Which support we need is that 2 liters per minute is sufficient, or do we need more support? And then, and this is one of the main points, we have to be better in prevention of device-related complications. So device malfunction, limb ischemia, hemolysis, bleeding, infection, all these are issues which contribute to overall mortality. And we should not forget about these problems with our devices. So what are the results so far? Impella versus ERBP, this is a match comparison, no randomized trial, which we did. And you see here, after 30 days, no hint for an improved outcome with the Impella. There is an ongoing trial, the Dangerous Shock trial, which will include about 360 patients and will have this inclusion criteria, including lactate above 2.5 ml, and the statistical assumption looking for a reduction of 12% in overall mortality. I think they are now over 200 patients, and they will need some more time to get the results. And these are the problems of these randomized trials in cardiogenic shock. So we will have a cohort which will survive anyway, whatever we do. And these patients will have the problem that they have, if you put a mechanical support device in, you will have the problems, so bleeding, infection, and the patient possibly will die because of these problems. And then we will have a cohort, so they will die anyway, whatever we do. And there are about 20-25% left where possibly a mechanical support device will improve the outcome. And the problem is to identify these patients. With respect to ECMO, we have a small randomized trial which was not powered to look on mortality. However, there was some benefit with respect to 30-day mortality in this small trial, but the overall mortality was quite low. And currently, 2 randomized trials are looking for ECMO in shock. The first one is the Ecls shock trial. And here we are randomizing patients after or before PCI to Ecls versus the standard of care. And the primary outcome will be 30-day mortality. We are looking for severe shock, so we are including just patients with an arterial lactate above 3 ml per liter. And now we are almost halfway, so we have included 200 patients. We are aiming for 420. And in parallel, the EuroShock trial is running almost the same design. The only difference is that the cardiogenic shock should last for 30 minutes after culprit lesion PCI, so you do not have the possibility to put in the ECMO before PCI, but the outcome measure is the same, 30-day mortality. Assumptions are 50% mortality in the control group and a reduction to 36% with ECMO. As far as I know, this trial is not so advanced so far. So we try to give some hint for what you should do in cardiogenic shock with respect to mechanical support devices in this position paper. And impeller and tandem heart and ECMO, if you have left ventricular dysfunction predominantly, if you have a problem with oxygenation, ECMO certainly is fine. We don't have that much experience with right ventricular function. So this is at the moment what we know. Clearly, we have problems with ECMO because of stasis, because of this problem that we should do ventings. And we have these venting options. So we have additional intra-aortic balloon pump insertion. We have impeller, atrial with drainage to the left atrium by a catheter. And we have pulmonary arterial drainage with a connection by a venous cannula of the Ecls. So we can do transaortic venting by pigtail catheters. So we have one easy approach. We have another easy approach. This is quite demanding in the setting of cardiovascular shock. And this is what we have to discuss. Is impeller insertion justified in a major proportion of patients? We have one positive trial. This was not a randomized comparison. This was the ECMELA approach. So patients on ECMO in cardiogenic shock of different causes. And here, after 30 days, there was a reduced mortality, p-value of 0.03. Again, no randomized comparison. However, this approach certainly is more aggressive, and therefore severe bleeding complications were seen more often. So odds ratio almost 3, and excess-related ischemia, again, more often with the ECMELA compared to ECMO alone. What are the results of the other approaches? Intra-aortic balloon pump. Here you have the non-randomized comparison of impeller, and then transeptal left atrial cannula. You can see here that overall there was a benefit of ECMO venting in different indications, but it seems that intra-aortic balloon pump is as effective as the impeller. So in the Ecls shock trial, we have a clear strategy. So patients should not put on an impeller on a routine basis, but if you have no arterial waveform pulsatility, no aortic valve opening in the echo, or velocity of the left ventricular outflow plug of more than 10 cm, then you should think about venting, and especially if you're increasing diameters and volume of the left ventricle. So it's not a routine strategy, but you can do it. And the possibilities which are there, I have showed you. So there are 2 randomized trials ongoing with this ECMELA approach. The first one is a reverse trial with about 100 patients. So patients with cardiogenic shock of multiple etiologies will be randomized to just VA ECMO or VA ECMO and impeller. Primary endpoint is a combined endpoint. So it's not just survival, it's survival free of mechanical circular support, heart transplantation, or inotropic support at 30 days. The trial is still ongoing. And the colleagues in Hamburg who did this unrandomized comparison, they are performing this LV unloading anti-ECMO trial with the impeller device. So patient in cardiogenic shock will be randomized to impeller or not. And after 100 patients, they will do an interim analysis. And then if this is positive, go on to a larger trial. So far, I think clearly there is a need for venting in patients with ECMO. And I have shown you the indications for venting. I'm not sure if impeller is the way to go. it certainly increases complication. And bleeding complication sepsis is clearly related to mortality. No question, it increases cost. It's technically demanding, so there might be only a few centers who are able to perform this therapy on a routine basis and without too many complications. So far, there's no proven benefit. I've shown you the trials which are ongoing. The problem is timing. If you do it early, you will maybe increase complication rate without having any benefit. We have cheaper and safer alternatives available, for example, intra-aortic balloon pump or just a pigtail. So on a routine basis, let's wait for the results of the randomized clinical trials. And so far, I would say keep it simple and go for the easier methods. Thank you very much.
Thank you, Professor Zeimer. Are you going to also present some slides of Professor Enriquez, or should we start?
So his slides actually were more or less the results of this non-randomized comparison of the Hamburg group, and some slides with respect to this early unloading, but not in cardiogenic shock, just in STEMI. And you might know the results of this trial. So it just shows that you can do it, that you can put the impeller in first and then do primary PCI, but I don't think it relates to this problem of early venting. So it shows that you can do impeller before primary PCI, but I think we really have to wait for this randomized clinical trial before we can say that early impeller is not only beneficial on a theoretical basis, which is the case. I mean, we all agree that it's a very effective device and that you can prevent venting, but we have increases in complication, and it has to be shown that the overall benefit is there, and therefore we need these trials, and these trials are ongoing. And before I have these results, I would rather go for intra-aortic balloon pump or so, and on a routine basis. We do it quite rarely, to tell you the truth.
Thank you very much. Felix, would you like to start the Q&A?
Yeah, actually there is one question that I would like to ask Professor Price. I would like to know, is there a typical patient where you would not try weaning from ECMO, not based